I'm Dr. Arthur Jones, and the topic for this presentation is geriatric respiratory care. Although most of us do not intentionally focus on geriatrics, there is little denying that our respiratory care patients mostly are elderly people. Furthermore, lots of respiratory therapists are getting there too. So, like it or not, we practice geriatric respiratory care more than we know. Now, please understand that you must listen to all of the audio and visit all of the required web links to receive credit for this lesson. Time has been allocated within the lesson for you to do so. The non-required links are marked as FYI. Here are your learning objectives for this presentation. When you finish here, you will be able to describe the prevalence of cardiopulmonary disease among the aging population, and you will be able to describe special problems among geriatric patients as well as accommodations that respiratory therapists can implement in caring for them. This first section of the lesson is a discussion of aging and its effects on health. That is, what we all have to look forward to if we live long enough. We'll begin by defining a couple terms. First, geriatrics is defined as a branch of medicine that deals with the problems and diseases of old age and aging people. Gerontology, on the other hand, is the scientific study of aging and problems of the aged. There's no doubt about it, the population is aging. In fact, a group of prominent researchers has discovered that there is a significant correlation between the passage of time and aging. What has changed is our definition of what we consider to be old. It used to be that 65 was considered elderly, but baby boomers have redefined old age as more than 79 years. We'll see if that changes when the baby boomers get there. More and more people are defining agedness in terms of limitations. That is, if they can still do what they want to do, they are not old. Although physical and physiologic changes with aging differ among individuals, similar changes do occur with age. Central nervous system changes include loss of neurons, a slowdown of nerve transmission, memory loss, and slower reflexes. Sensory loss also occurs and includes loss of hearing, which is accelerated by noise like loud music, especially bass, and also decreased visual acuity. The musculoskeletal system also changes with age. Our bone density decreases, which gives us a greater predisposition for fractures. The muscle mass decreases also. We experience arthritic changes, and all of these together contribute to decreased mobility. In the absence of disease, the kidneys do not change much. There is some loss of nephrons. However, kidney function remains relatively normal unless there is damage from urethral blockage, such as from the prostate, and also from people who develop diabetic end-stage renal disease. And we're seeing more and more of these folks all the time. The most common health complaints among geriatric patients are gastrointestinal. The more common ones are reflux, constipation, and incontinence. The liver also ages due to prolonged exposure to toxins and free radicals. I always said that those radicals should not be free. As a result of the aging of the liver, there is slower metabolism of drugs that are processed by that organ. This means that some drugs will hang around for a long time. Changes with aging on the heart include increased endocardial thickness, increased left ventricular wall thickness, left atrial hypertrophy, and decreased sinoatrial cell numbers. The vascular walls also change with the deposition of atherosclerotic plaque, which decreases their lumen. All of these together increase the risk of geriatric patients for hypertension, ischemic heart disease, and congestive heart failure, usually of the diastolic type. The lung also changes with age, and we know that the lung ages much faster in some individuals than in others. Smokers, that is. These changes include a decrease in numbers of alveoli and alveolar capillaries, reducing the surface area for diffusion and causing ventilation-perfusion mismatching. There's a loss of elastic tissue and recoil, which increases lung compliance, decreased costovertebral joint mobility, which decreases thoracic compliance, and decreased expiratory flows due to the increased lung compliance and airway collapse. There is a link at the bottom of the page where you can see an article with illustrations on aging of the lung. The net effects of these altered pulmonary mechanics include a decreased total compliance, increased work of breathing, and decreased cough effectiveness. Additional consequences of aging include impaired mucociliary clearance and also decreased numbers of alveolar macrophages. Together, these effects reduce the ability of the lung to remove foreign substances and therefore increase the risk for infections, that is, pneumonia. Aging also blunts the ventilatory response to hypercapnia and hypoxemia, which increases the risk for sleep apnea. Other changes include a decrease in the arterial PO2 to about 80 at 75 years old, then it normally stabilizes. However, I'd like to mention that I've done many blood gases on patients who were older than 80 who had room air PO2s that were greater than 90. The diffusing capacity also decreased with age due to the decreased numbers of alveoli. An important point here is that aging of the lung is accelerated by cigarette smoking. In fact, recently, smoking cessation experts advise us to inform smoking patients of their pulmonary age as a strategy to encourage quitting. Another change that accompanies aging is a decrease in the numbers and sensitivity of beta-2 adrenergic receptors. The implication of this is that some of our geriatric patients will not respond to beta-agonist bronchodilators like albuterol. Aging also causes a decline in immunity, which predisposes to infections and cancer. Elderly people also experience difficulty swallowing or dysphagia and reflux. These predispose to aspiration. That pretty much sums up what I've got to say about aging and health. Next, I'm going to describe some of the conditions that we are likely to find in our geriatric patients. Pneumonia is a big one. Before antibiotics, around 1945, infections like pneumonia were the leading cause of death. Furthermore, those who did survive pneumonia often developed some pretty serious complications, like bronchiectasis and lung abscesses. Currently, pneumonia is the fourth leading cause of death in elderly, and it continues mainly because microorganisms have developed resistant strains such as methicillin-resistant Staph aureus. In the previous section, I mentioned some of the factors that make the aging lung more vulnerable to infection. There are also non-pulmonary factors that increase susceptibility to pneumonia, and these include poor nutrition, which impairs immunity and causes general debilitation, immobility, which impairs mobilization of secretions, comorbidity, that is, the presence of other diseases, institutional residence, such as nursing homes in which resistant microorganisms seem to run rampant, and, as I already mentioned, dysphagia or inability to swallow, which increases the risk for aspiration. A big problem with pneumonia in geriatric patients is diagnosing it. In many elderly patients, the only signs may be first a change in mental status, which may be difficult to detect, especially in those suffering from dementia. Then there are tachypnea and tachycardia, which could signify a plethora of conditions. The usual indicators for pneumonia in other patients groups have been found unreliable in geriatric patients. These unreliable indicators include fever, cough, dyspnea, auscultatory signs, and even the chest X-ray. A diagnostic strategy that has been found reliable is the Community-Acquired Pneumonia Risk Score. There is a link at the bottom of this slide that will enable you to see how this works. For each patient, points are assigned based on demographic and clinical data. Then risk is classified on a scale of 1 to 5 based on those points. The total score determines the likelihood of a given patient's risk for pneumonia. Note, however, that this applies only to community-acquired pneumonia. There is another scoring system for diagnosis of ventilator-associated pneumonia, and there's another link at the bottom of this slide for you to download an article about it. Pneumococcal or streptococcal pneumonia can be prevented with a vaccine. This vaccine is recommended for everyone who is 65 years old or older, or if they're at high risk, for instance, residents in a nursing home. A booster vaccination is recommended 5 years after the first one. Flu vaccine can also prevent pulmonary infections first by preventing viral pneumonia resulting from the flu, and also by preventing secondary bacterial pneumonia that also results from the influenza. For some reason, we want to relate asthma with young people. However, this is not the case. In fact, asthma is widely underdiagnosed and undertreated in elderly patients. It's a big problem with them. There are two types of presentations among these patients. First, there is late onset asthma that usually appears after 65 years old. This is not associated with allergies. However, it has been found to be associated with hormone replacement for menopause, especially in females. Then there is the long-standing type. This is associated with allergies, and many of these people will tell you that they had asthma as a child that went away, then came back with a vengeance. There are several confounding factors pertaining to asthma in our geriatric patients. First, some of these patients are unable to cooperate with spirometry. Also, they may have impaired response to beta agonists, which will mask any reversibility. Finally, it's easy to confuse it with other conditions because its manifestations resemble COPD and also congestive heart failure, which also known as cardiac asthma. Another common problem among our geriatric patients, of course, is COPD, chronic bronchitis, emphysema, which is a primary or contributing admission diagnosis for 18% of patients over 65 years old. So that is close to 1 out of 5 patients being admitted. Aging of the lung is accelerated by smoking, so for this group of people, smoking cessation is the most important, although the most difficult intervention to achieve. COPD has many associated complications. These include systemic inflammation, which affects multiple organ systems, pulmonary hypertension leading to cardiopulmonary right heart failure, congestive heart failure, secondary polycythemia, atrial dysrhythmias which predispose to pulmonary emboli, and finally pneumonia, which is a common cause of COPD exacerbations. Another category of lung disease that we see in geriatric patients is interstitial lung disease. As you know, these are restrictive lung conditions that decrease lung compliance, lung volumes, and diffusing capacity. This category includes interstitial pulmonary fibrosis, which is a progressive and terminal condition, drug-induced lung disease, such as those associated with amiodarone. It's important for you to know that this drug also increases the risk for pulmonary oxygen toxicity. Occupational lung diseases also are included here. Many of our geriatric patients worked in hazardous work environments prior to safety regulations and devices like respirator masks. Connective tissue disease, such as rheumatoid arthritis, also frequently has pulmonary involvement. The link at the bottom of the slide will take you to an article on drug-induced pulmonary oxygen toxicity. Geriatric patients also commonly have sleep-related breathing disorders such as obstructive sleep apnea, because the prevalence of this increases with age due to diminished ventilatory drive, altered sleep patterns with aging, and a greater number of central apneas. The complications of these sleep-related breathing disorders include increased cardiovascular deaths in the elderly, especially in females, hypertension, and diabetes. The implication of this is that we are going to see more and more CPAP and BiPAP placed in nursing homes and in residences. Congestive heart failure also is prevalent among the elderly. This can be left and or right ventricular pump failure. This is a prominent cause of disability and of nursing home admissions. The causes of CHF include first, pulmonary disease leading to cardiopulmonary right ventricular failure, also hypertension, cardiomyopathy, valvular disease, ischemic heart disease, and myocytic apoptosis, which is programmed myocardial cell death. If you click on the link at the bottom of the page, it will take you to an article on cardiomyocytic apoptosis. The manifestations of congestive heart failure can include combinations of chain-stoked breathing, tachypnea, dyspnea, hypoxemia, orthopnea, wheezes, rhonchi, and crackles on auscultation. And the question is, when we see this patient, is it congestive heart failure, pneumonia, and exacerbation of COPD, or is it all of the above? We also see a lot of geriatric patients with cerebrovascular disease. This is a very common cause of death and disability among the elderly. The complications of cerebrovascular disease including paralysis, which is often unilateral, dysphagia, which predisposes to aspiration, dysphonia, inability to speak, and sometimes coma. Cerebrovascular accidents, or CVAs, can be due to emboli, which cause ischemic strokes, cerebral hemorrhage, and also transient ischemic attacks, or TIAs, which are also known as mini strokes. Often we see these people as trauma admissions because we don't know if the fall caused the stroke or the stroke caused the fall. The incidence of cancer also has increased over recent years. The main reason for this is that increased longevity has increased the incidence of cancer. That is, people died of something else, like pneumonia. Also implicit with aging is a longer duration of exposure to carcinogens of all types. There are several types of cancer that are particularly age-related. These include cancers of the pancreas, stomach, colon, prostate, and breast. For many of our geriatric patients, their symptoms may be masked by comorbidities, by other diseases. Also, they have a fear of the diagnosis, and that may prevent them from seeking care. We also need to carefully consider the benefits versus the risk for interventions to manage cancer. For example, let's take an 85-year-old who's been diagnosed with lung cancer. He also has congestive heart failure and COPD, and the option for a cure is a lobectomy. Possibly he will survive 1 year without the surgery. On the other hand, there is a strong likelihood of ventilator dependence if he gets the lung resection. So the question would be to cut or not to cut. Should he take a year with palliation and comfort measures, or the possibility of ventilator dependence for the rest of his life? There are, of course, other predispositions among the elderly. One of these is end-stage renal disease that we see especially in diabetics, and we are seeing more and more dialysis patients in their 80s and 90s. Trauma is also a high risk for these patients because they have osteoporosis, which increases the risk for fractures. Elderly patients also are at increased risk for any post-operative complications, first because of comorbidities, deconditioning due to their immobility, and also the possibility of malnutrition. Geriatric patients present with difficulties in diagnosing their primary problem. For one thing, the symptoms can be confusing. For example, a cough can be caused by any of these: ACE inhibitors like captopril, postnasal drip, reflux, or even asthma. Another symptom, dyspnea, may be perceived by patients as a normal condition with aging. Wheezing is yet another. This can be caused by airways disease or by congestive heart failure. Additional diagnostic problems involve medical imaging where positioning can be a problem, especially when we need to place patients with congestive heart failure in the supine position. There also are difficulties with pulmonary function testing. First, patients may be unable to cooperate with the test due to cognitive impairment or physical impairment. And frequently, the age of the patients is beyond the age normal for predicted values. The forthcoming section will describe some of the barriers to care for geriatric patients and how we can accommodate them. That is, how we adjust our care to meet their needs. Symptomatology can be a problem with geriatric patients because symptoms may change with aging. Also, many of these patients are unable to relate their symptoms to us due to mental impairment. Nutrition is yet another difficulty. Sometimes the elderly even forget to eat, and they become malnourished, which predisposes to immunosuppression and delayed wound healing. Many of our geriatric patients also suffer from decreased mobility, which for one thing impairs their access to care, but it also causes deconditioning with such a vicious cycle. That is, deconditioning impairs their mobility, which leads to further deconditioning, etc., etc. Geriatrics poses problems pertaining to pharmacology as well. For one thing, there's difficulty with adherence to dosage schedules, which is difficult because of impaired memory. Also, most of these patients are on multiple medications from multiple physicians, which increases the risk for drug interactions. And their decreased liver and kidney function slows the clearance of medications from the body. As pointed out earlier, geriatric patients may have a decreased sensitivity to beta agonist drugs, which will impair their response. They also are at increased risk for adverse effects, particularly from drugs such as corticosteroids, which cause osteoporosis, and xanthine, such as theophylline, which is subject to many drug interactions. As you probably have experienced many times, another problem we have with our geriatric patients is inability to take aerosolized drugs. Problems with their hands, such as arthritis, may make it impossible for them to actuate meter-dose inhalers. And also coordination problems and palsy, such as Parkinsonism, may make it impossible for them to coordinate. Also, many geriatric patients are unable to generate the inspiratory flow necessary for dry powder inhalers. Although this is not universal, the mental status of geriatric patients may be problematic. It can be difficult to assess changes in mental status, especially in the presence of dementia and dysphonia. Impaired cognition may interfere with their adherence to therapeutic. Sensory impairment also is common in these patients, particularly hearing and visual impairment. Combined, these impairments produce bidirectional communications barriers, which interferes with our care. Finances can be another barrier because patients may not be able to pay for necessary services and medications. Some geriatric patients are faced with the decision of paying for medications or for food. Also, these patients often live with worry over their ability to pay. Families can either be a tremendous help or they may be a hindrance to appropriate care. Elderly patients also are at increased surgical risk and may be prone to multiple organ system failure. Therefore, in elderly patients, it is preferable to apply the least invasive procedures possible. Psychosocial barriers to care include the evaluation of the elderly both by themselves and by some caregivers. We need to adopt an attitude of caring for these patients. First, we must respect the patient and treat them with respect. I don't think that it is respectful to address elderly patients by their first names, and I don't do it until they ask me to. This puts me in disagreement with HIPAA. I realize that. We also need to identify and accommodate sensory impairments the patient may have. Despite productivity demands, we need to take time with these patients, and frankly, I enjoy it. Finally, we need to encourage the patients taking personal control. They are patients, they are not children. Now, where do we care for these patients? We spend a lot of time with them at acute care hospitals. Of course, this is the most expensive alternative. So acute care hospitals are discharging their patients sicker than they used to be. Home is the least expensive alternative. The caregivers can be family who do require some respite, a vacation from this care. Home healthcare personnel are another big plus, including home care respiratory care practitioners who can play a very important role in the care of geriatric patients. Then there are long-term care facilities like nursing homes. The majority of the patients there are admitted for dementia. There is a trend towards sicker patients being in the nursing homes, and also there is a greater female population. That's because they live longer. The most important function of a nursing home really is some degree of rehab. That is restoring the patient's ability to do the activities of daily living. Also, these are geared towards caring and not curing, and often the long-term care facility is there for terminal care of the patient, that is hospice care. There is often a great non-financial cost to moving elderly patients to long-term care facilities. That is relocation or transfer trauma. Imagine a 90-year-old woman or man who's been independent in their home for many years, then is committed to a long-term care facility where they lose their independence and control. There is a high death rate among elderly patients for the first 90 days after admission to a nursing home. The causes for this high death rate include environmental change, loss of personal control, and loss of the will to live. Now let's talk about respiratory therapy for these folks. Supplemental oxygen is one of the most important therapeutics for these people. It's indicated for chronic hypoxemia, an arterial PO2 of less than 55, a saturation less than 88. The benefits are tremendous. It does increase survival. It improves the quality of life because it enables some of the activities they may be unable to do without the oxygen. Supplemental oxygen will reverse polycythemia and also, to a certain extent, reverse pulmonary hypertension. We do know that the use of home oxygen will only increase over the years. Accommodations involving aerosol therapy first point to patient education. It needs to be adapted for sensory impairment. Brochures with large print we need to repeat, and also we need to follow up with these patients to ensure that they are doing the way we taught them. It also is very nice to minimize the frequency of medications to improve adherence. Therefore, a once-a-day medication is far better than a 4 times a day medication, especially for these patients. We need to be sure they get administration devices that they can use. We know that many of them cannot use a standard MDI, so our alternatives include new generation non-pneumatic nebulizers. Some of these can deliver a full dose of medication in a couple of breaths. These patients also may be able to use a spacer with a mask if lip control is the problem. Then there are breath-actuated inhalers, which include the AirMax Gold, AutoHaler Gold, Easy Breath Gold, and the microdose dry powder inhaler system, which has lots of potential. Here's a list of medications that are available on the breath-actuated inhalers. The AirMax Gold is budesonide or Pulmicor. AutoHaler Gold has albuterol or beclomethasone or phenodrol and Atrovent. Easy Breathe Gold has albuterol and beclomethasone. I have personally wasted many hours doing pulmonary clearance procedures that were not indicated or were ineffective. These procedures include incentive spirometry, which in the first place, many geriatric patients simply cannot cooperate. Many of them also were never taught the correct procedure. And finally, there is not a shred of scientific evidence that there is any benefit from incentive spirometry. Percussion and postural drainage is another. We can indeed produce trauma from percussing these patients. We can also cause vomiting and aspiration from the drainage positions, and there also is no evidence of benefit for routine use of chest physiotherapy that is percussion and postural drainage. Pulmonary clearance techniques that might work for these patients and might be safe include expiratory pressure with vibration, the acapella, and also the vest. Patients who cannot work with the acapella device with a mouthpiece can still do effective therapy with the device attached to a tight-fitting mask, such as the mask we use for bag mask ventilation. I've done this, and it works. We sometimes question the decision to ventilate geriatric patients, and it is reasonable to question this when the patient has an advance directive stating that they do not want it. On the other hand, 2 studies found that given similar severity of illness, elderly patients had a similar time on the ventilator and even lower cost of care than younger patients, and the researchers concluded that ventilation should not be restricted solely on the basis of age. There is a link to one of these articles at the bottom of the slide if you'd like to download it and read it. There are specific precautions pertaining to these patients and mechanical ventilation. First, keep in mind that the risk for ventilator-associated pneumonia is increased in patients from nursing homes. Also, that these patients are likely to have weakened lung parenchyma, so we need to be cautious to prevent volume trauma. And also keep in mind that there's a strong likelihood of comorbidities, such as congestive heart failure. That concluded the new information for this lesson. Let's review and summarize for a bit. We began by talking about the effects of aging and the effects on the central nervous system, the musculoskeletal system, the kidneys, the GI tract, the circulatory system, including the heart, and also on the lungs. Then I talked about some of the prevalent conditions among geriatric patients. These included pneumonia, asthma, COPD, interstitial lung disease, sleep-related breathing disorders, congestive heart failure, cerebrovascular disease, cancer, and end-stage renal disease. I mentioned some of the problems in diagnosing these patients, their symptomatology, problems with imaging and pulmonary function testing, Also, the barriers to care for these patients, including their symptomatology, nutritional status, their tendency to be immobile. Talked about pharmacologic problems and also problems associated with their mental status, sensory impairment, finances, and psychosocial problems. Then I talked about the need to adopt an attitude of caring for these patients, one of respect. I identified the various care sites at which we'll be caring for these patients and talked about the respiratory therapeutics geared to these patients, supplemental oxygen, accommodations for aerosol therapy, pulmonary clearance techniques, and finally, mechanical ventilation.